So I only see patients with kidney cancer. I have a lab focused on kidney cancer and run clinical trials for kidney cancer, investigator-initiated, with a passion for the rare ones. So 50% of the patients in my clinic have clear cell, and the other 50% have non-clear cell. I see between 3 to 8 patients with renal medullary carcinoma per week. So I just saw 3 patients with RMC, renal medullary carcinoma, just today. So what for other teams may be very rare, to us, it's kind of bread and butter. So these are my disclosures. None are related to today's talk. And the first thing that I really wanted to highlight is that, you go on the internet and you see the FDA wisely, because it gives us the flexibility, approved various therapies for kidney cancer, renal cell carcinoma. They don't specify necessarily usually the subtype, which gives us the flexibility. But and there has been a huge amount of progress. There is no doubt in those FDA approvals, but they were all based predominantly, and in many cases exclusively, on data from clear cell kidney cancer trials, not on studies in other histologies. And when we were starting our rare kidney cancer program at MD Anderson, we felt that this is unfair because, yes, clear cell kidney cancer is 75% of all cases, but then you have the other 25%. It's a big number, comprised of many, many other subtypes, of which we decided to focus on RMC initially, renal medullary carcinoma. Why? Because it is one of the deadliest. It probably is the deadliest of the kidney cancers in adults. If left untreated, the average survival is 4 months from diagnosis. That's it. 4 months from diagnosis. Very tough, very difficult, and it's the only cancer, to my knowledge, that so specifically afflicts a minority. Young individuals of African descent in the United States, young Blacks. So young, very often, not having insurance privileges, etc. Difficult challenge. People did not want to face it, and we faced it head on, and we made a difference. But until that happened, when we were first starting our program and I was looking to see, what should I specialize in, I did get the feedback, not from people here like Matt. Matt said the exact opposite to me, but others, people would say, oh, this is an academic suicide. And I think that now it's very easy to say, oh, look at what they're doing. They've done all this good work in RMC because it was easy and straightforward. In retrospect, it sounds straightforward, but it wasn't. It was hard. And what I want to show you is how to also advocate for yourselves, to push for better diagnosis of your tumors, better management of your tumors, more research. Why? Because this counts for both rare and common diseases. And so the nice thing about focusing on rare diseases is that if you think about it in a certain way, every single patient with cancer or kidney cancer in the world has the most rare disease in the world. Only they have it. It belongs to them alone, in a sense. And so if you understand how to tackle a rare kidney cancer, you can understand how to individualize care, which is the holy grail of medicine. And to attack that, the first thing that we had to crack is this seemingly very simple question. This is a law of nature. This is not just kidney cancer or rare kidney cancer. I teach this to theoretical physicists and statisticians. So this is a law. You're doing a study. As the number of patients enrolled in a study, in a clinical trial, let's say, any clinical trial, or an observation study, or a study in the lab, there is no trick. As the number of patients increases, the probability that the results you're going to get include the truth. A, increases. 2, decreases. 3, remains the same. 4, I have no idea. This is a law of nature related to forecasting. Even if you want to do political forecasting, let's say, this is the law of nature that applies. Most people, when you ask them, they say, it increases. You increase the sample size, of course it's going to increase. Decreases, it's a minority, remains the same. Some people would say, a little bit more nuanced. I have no idea, some would say. This is MD Anderson faculty and fellows. That's their answer. And the answer is it decreases. It's very, very, very counterintuitive because, hey, life is counterintuitive. It decreases. And once you understand this law of nature, you can flip the narrative and then make a difference for patients, including for RMC and other rare and common cancers. Why? Why is this the case? Because of something that in medicine we can call the relevance robustness trade-off. There's always a trade-off. What is that? Relevance for a patient is the opposite of bias. It signifies the trueness. It answers the question, is what I'm saying true for my specific patient? Is it relevant for my specific patient? And you can have the truth here. And always, whenever we think about, what is happening to a patient, there's always a distance from the truth because we don't know everything about a patient. And then the other aspect is what we call robustness, which sometimes we use the name variance for it. So robustness means that if I change a little bit the conditions, like let's say the patient is a little bit different, it's not exactly the same, are my inferences still the same? And the more robust something is, the more it applies to groups of patients. And always, 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 there is this trade-off between relevance and robustness. If every time that we try to make any single research decision or clinical decision for patients, that's the trade-off we're dealing with. This is the best way to visualize. This is a bed that is highly, highly relevant to a specific patient or individual at a specific point in time, but it is not robust. This is it. I'm telling you, this is a law of nature. Relevance and robustness trade-off. The more general term across all of science is bias variance trade-off. It's the same thing. Relevance and robustness is just the medical application of this law of nature. Now, how does this apply to everything we're talking about? So here's the truth. The truth is what we're always trying to find, but it's always beyond us. Nobody in this world knows the exact truth about something. Nobody, at least for now. Because we don't know the truth, we always have to make models, always. For everything we do, we make assumptions and models. Some of them we know that we're biasing them. We know we're making assumptions. Some of them we don't even know. We call this irreducible error. So there is always some distance from that truth, always. Now, everything else being the same, if I have a small sample size, my error margins, which are a function of the sample size, will be wide and thus more likely to contain the truth. Everything else being the same, if I increase the sample size, my uncertainty margins will reduce around my assumption, not around the truth, which is unknown to me, and thus the chances that it will include the truth reduces. That's it. That's what people stumble upon. This is real. This was published in Nature, one of our main journals, in 2021, and it was during the COVID pandemic where the vaccine, the COVID-19 vaccine, had been identified. And here you can see in the gray how many vaccines were used by the United States, by the CDC per month. And the challenge was, before the vaccines were deployed, could we predict how many people are going to take it? And there were 3 different surveys to try and do that. The first one was made by Facebook, Delphi and Facebook, which is the largest public health survey ever conducted in the US. And this is, by the way, why Facebook is not going to conquer the world anytime soon. It's in blue right here. You can see how far away the Facebook survey was from the actual truth consistently, exactly because of its huge sample size. You can see that its error margins are not even visible, completely off the truth. And then an intermediate study did it a little bit better, and then a survey in just 1,000 patients, so much more smaller, but well conducted, consistently got the truth right. That's in red. A picture is worth 1,000 words. Once you understand this, then you understand, and as I told you, this applies to everything. This work has been cited. Our papers in medicine on this related to rare kidney cancers have been cited by papers analyzing large hadron collider particle physics data. That's how big of a law is this. Once you understand this, you can flip the narrative and do research for rare tumors and common ones, and make meaningful changes like what we have been doing for renal medullary carcinoma. How? In order to reduce that bias, that distance from the truth, every time we look at data, we need to think, what are the underlying mechanisms that generated the data? And this is, some very big figureheads in data science that, are highlighting how we have been able to also popularize these concepts to the world, including to you guys today, to keep advocating for this. How does this apply now to kidney cancer? Perfect robustness. How do I get perfect robustness? If I could randomize everything, that's what the perfect randomized trial, that's every time you hear about randomized trial, that's what they're trying to do. They're trying to give you robust data. But a perfect randomized trial would mean that I randomize everything, not just the therapy, but even the sample of the patients that I'm taking, which we never do. If we could do that, we would not need to think about mechanisms. We would not need to think about everything, but we cannot do it. And remember, randomized trials were originally developed to optimize crops in agriculture, but patients are not plants. And so relevance is important. And what is the perfect relevance? If I could know everything about my patient, about their biology, their environment, their goals and values is a very important thing. Even the Krebs cycle, everything. But we can never know our patient perfectly. Hence, there is a trade-off. No free lunch, always a trade-off. And so in this arc of robustness and relevance, because let's say clear cell kidney cancer, yeah, it's 75%, but it is what we call heterogeneous. It's different. Not every patient with clear cell kidney cancer will behave the same. You guys know this. They are different. So for now, until we get to be more relevant with clear cell kidney cancer, we need to do randomized trials. But for rare kidney cancers like renal medullary carcinoma that are so, we call it homogeneous, so well defined biologically, we don't need to emphasize robustness. We can focus on the relevance, and we can make a difference for these patients and push the needle forward as we have been doing. And the exact same thing can be done for other cancers. So if you, for chromophobe, as long as we keep it as molecularly homogeneous as possible, or papillary, if we call it generally papillary, we need robustness. If we go deeper into what makes papillary biologically, we can break it down into subsets like FH deficient, etc., and produce results. This is what we call the renal medullary carcinoma framework. I mentioned before, predominantly afflicts young Blacks. You can see our patient advocates like Ritzy Johnson right here, who made a difference. None of these things that we have been doing would have happened without our patient advocates pushing, without my mentor Nizar Tanir spearheading the efforts to build this program to help patients with RMC. And their uniting goal, eradicate this cancer. And here are the results. In 1995, when it was first described, 4 months median survival from diagnosis. Between 1998 and 2011, about 8 months. Then a key event was the death of Chris Johnson, leading to patient advocates to organize themselves and push for research with RMC, Nizar Tanir being motivated by that key event, and boom, organized therapy. We start getting the first patients in remission. Today, up to 10% of patients with stage 4 RMC, we render them disease-free, thought to be impossible a few years ago even. A few days ago, as Nizar very well knows, we were able to repurpose therapies for RMC again, based on our emerging biological knowledge. And now we even have a 4th-line therapy for RMC that appears to be legitimate. This now means that RMC has as many mechanisms of actions for treatment as clear cell kidney cancer. But because it started from such a bad place, so aggressive cancer, we need to do far more. We cannot rest, and we have much more to do. We now know internal data from 135 patients with RMC treated at MD Anderson that the median survival is 18 months at least. We have said openly that we're going to get it to 2 years by 2025. As Nizar knows already, we are very well getting ready to get there, and we probably have already reached it, and 5 years by 2030, again, by using these frameworks. And it's important along these lines, listen to our patient advocates, push for research, dedicated trials. We need to have, similarly as the NCI did for FH deficient HLRCC, do trials for this disease. As we did for renal medullary carcinoma, we need trials specific for chromophobe kidney cancer, translocation kidney cancer, who's the biology. And it's beautiful to see the Kidney Cancer Association exactly pushing us to this direction by partnerships, supporting advocacy and research that's helping patients that are in this room right here with you guys. And so, practical things now. If you have what is maybe a rare kidney cancer, getting accurate diagnosis, getting more relevant to your diagnosis is key, either through a surgery or biopsy. And if you have a rare kidney cancer like RMC or anything else, and your physicians are stumbling, they can contact us. They know this. I talk to physicians every single day from all over the world, to today, and even though I have clinic, we'll always be happy to help. It's much better if we talk to physicians rather than patients. It can be confusing and unfair to patients if, you know, we just say things unfiltered. It's mainly, it becomes noise. But if the medical teams contact us, we're always available pro bono to help. And so with regards to therapies, the broad terms, you've heard that already. We have localized therapies that we can use for any kidney cancer, including the rare ones, and the localized can be things that address the cancer in a specific area like surgery, radiation, ablation, and etc. And we have to keep in mind that certain types of kidney cancer, on average, that may not be relevant to specific patients though, may be less likely to come back after surgery, in which case, you know, just surgery may be enough for this, like chromophobe and papillary kidney cancer. But other subtypes like RMC, renal medullary carcinoma, are so angry that they almost never will be cured by just localized therapy. They need broader therapies, which we call systemic therapies, those that goes all over your system. And in the past, you know, we used to give these immunotherapy cytokines mainly for the clear cell subtype. The other subtypes, not really, don't work as well. And then we have things like targeted therapies, mainly developed for clear cell kidney cancer, although now we have targeted therapies for renal medullary carcinoma. We need more targeted therapies for the other subtypes that are biologically driven. Immunotherapy, again, developed mainly for the most common subtype, but can work in some of the other ones as well. And chemotherapy does not work, the classic old school chemotherapy that everybody has heard of that you give in prostate cancer or breast cancer or whatnot. It doesn't work against the more common subtype, clear cell kidney cancer, and many of the other subtypes, but it can work against some subtypes like renal medullary carcinoma, collecting duct, or Wilms tumors, etc. So this is why it's so important that you get the right diagnosis. And these are examples of, you know, how some subtypes might be sensitive or resistant to chemotherapy. Again, highlighting how important accurate diagnosis is. If you need to send your pathology to a tertiary center to have the right diagnosis, this is key. I very often talk with the folks at Mayo Clinic in Rochester, an amazing team of pathologists there. We really love to brainstorm, you know, these tough cases, talk about molecular biology. We're learning as well, all of us. The beauty of moving the field forward is how, you know, we're lifelong learners with these things. And so now, very, very rough thoughts again to show the contrast between the different subtypes. If you look at, let's say, the average clear cell kidney cancer, it has a lot of immune cells in the tumor, and many of them would be what we call, you know, the good cells, which we highlight with green, and some bad cells as well that, you know, we want to remove. Papillary kidney cancer, which is the second most common type of kidney cancer, in general, also has immune cells, but fewer of them than clear cell kidney cancer. Chromophobe kidney cancer does not have a lot of immune cells. We call this cold. So clear cell kidney cancer is hot because it has immune cell. Chromophobe is cold. RMC, renal medullary carcinoma, is also hot. It has a lot of immune cells, but it has a lot of the bad ones. So both chromophobe, kidney cancer, and RMC, if you give them the immunotherapy that we give for clear cell kidney cancer, it's not going to act the same. You already know, because the biology is so different. So you have to do different things for its subtype. You can tell even with this very rough sketch. And indeed, if you do what we call a meta-analysis, combine literally all the data known to date for the second most common kidney cancer subtype, papillary, and the third one, chromophobe, you can see that, oh, lo and behold, papillary, it responds, not as much as clear cell kidney cancer, which let's say the response rate is 50%, but it is on the range of 25%, exactly as predicted based on the very rough sketch I told you. But then you try to give it in chromophobe, which is cold, and the therapy was not developed for it. Of course, the response rate will be on the range of 5%. It's predicted. That's why those things need dedicated therapies, relevant therapies. So in summary, identifying the specific kidney cancer subtype for each patient is critical for proper management. That's the number one thing. Advocate for yourselves to get proper diagnosis. Biology-driven, target-specific trials are both needed and feasible to advance the field in the treatment of rare kidney cancer subtypes. And as I said, these research and patient-centered inferences, we can do them. There is no excuse anymore that, oh, you know, this is suicide. So the lessons learned from RMC and other subtypes like HLRCC can help patients with rare and common cancer. Patient advocacy matters. Advocate for yourself as a patient. It is okay to look things up and ask questions. And we're always happy to discuss cases and work with local oncology teams. This is, again, as you can tell, this is not the work of a single person. It takes a village. It's teamwork, and I would like to gratefully acknowledge that as well as our funding agencies. Thank you so much for your attention.